Okay, welcome. Sorry for that hitch. I want to make a few announcements that this webinar will attract 3 CPD points. It will take 1.5 hours. The first 1 hour will be for presentation by our speaker. And then the second bit, the other 30 minutes are for Q&A. So I advise all of us that whoever has got a question can direct it to the Q&A box instead of the chat box for easy identification. So today's topic is about the rise of superbugs, confronting the threat of multidrug-resistant organisms. And our speaker today will be Samuel Asendi. Samuel Asendi is a skilled medical laboratory professional with strong experience in clinical microbiology, antimicrobial stewardship, and infection prevention control. He has been actively involved in diagnosing and monitoring multidrug-resistant organisms at the Mombasa Hospital and works closely with the clinical teams to support evidence-based treatment decisions. He's passionate about strengthening laboratory capacity, improving diagnostic quality, and promoting responsible antibiotic use to protect patients and communities from the growing threat of antimicrobial resistance. So, Samuel, welcome. Are you able to hear me?
Yes, I can hear you, Bruce.
Thank you so
much. Are you able to hear me?
I'm able to hear you.
Thank you.
Welcome, and you can take the mic.
Okay, thank you so much, Mr. Bruce, for the introduction. And good afternoon, everyone. Thank you for joining. I'm seeing people are continuing to join. And today we'll be confronting one of the greatest threats facing the healthcare. These are multi-drug-resistant organisms, the so-called superbugs. We as the medical professionals and medical laboratory officers, to be specific, we are not just witnesses to this crisis. We are the ones who are the front line of diagnosing these MDROS. And to start us off, we shall define what MDROS are. And basically, these are bacteria that have developed resistance to multiple antibiotics, one or more, and even in some cases, all the available options that are there. These include the MRSA or methicillin-resistant Staphylococcus aureus and vancomycin-resistant Enterococcus. So these pathogens, we shall actually focus on case studies that we might have come across. Mr. Bruce. So we have, these are real life scenarios, and we can learn something from these outbreaks. These are some of the things that these are some of the case studies or the case reports that you can come or you can meet along during your day-to-day activities. For case study number 1, there was an MRSA outbreak in a surgical ward. This was a 40-year-old patient who had undergone surgery. And post-operatively, he developed an infection caused by methicillin-resistant Staph aureus. Subsequent testing revealed that the infection had spread to other patients. So what we'll focus on, or the discussion point that we should have as medical laboratory officers and also as healthcare providers, is the strategies that could have been implemented earlier to prevent that outbreak, or how healthcare facilities we can improve compliance with infection control measures, and what role do patient education and engagement play in preventing the infection. Okay. So when we did our audit, we found out that because it was a general ward and there were close quarters and they were sharing facilities like toilets and maybe the restroom areas, this facilitated the spread of MRSA. And also there was a problem with healthcare struggling with adherence to hand hygiene, which is basic. and also the infection control measures were not adequately enforced and followed. So in this case scenario, if strict isolation procedures for those infected patients had been adhered to, and screening patients and staff for MRSA, and also conducting training sessions, mandatory training sessions on infection control practices for all staff, and including environmental cleaning, could have enhanced or curbed the spread of this MRSA. So we also had another case study of vancomycin-resistant enterococci. In this scenario, it was a long-term care facility where like the elderly are placed, and there was an outbreak of this vancomycin-resistant enterococci, which affects several residents. So this vancomycin-resistant enterococci leaked even to the residents of that area. It was a hospital-acquired infection, but it leaked to the community. So many of these patients had previous antibiotic exposure, and this increased their susceptibility to VRE, or vancomycin-resistant enterococci. So what we pondered our mind over was, how would antibiotic stewardship been effectively implemented in such a long-term care setting? And what barriers could to compliance with infection control measures could have caused also this infection to spread more, because it was noted that maybe there was high staff turnover, staff resigning, and others new staff coming in, that is high staff turnover, and also the role that interfacility communication could have played in managing MDRO. So let's see what happened. So as we had earlier mentioned, the facility head majority were elderly, and they had multiple comorbidities and weakened immune system. These are some of the challenges or advantages that MDROs take over: those with comorbidities and weakened immune system, and also inappropriate prescribing of antibiotics could have also contributed to this, the resistant problem, and also high staff turnover. So you find yourself, the facility, you are spending much time training the employees or the medical practitioners and healthcare professionals in that facility, but you find that some of them tend to go for greener pastures, which we have seen currently, especially those who are going abroad to seek greener pastures, leaving behind untrained or less competent staff who are new. We call them rookie healthcare workers who are not that seasoned in infection control. So the management strategy of what could have been done in this case is to implement antibiotic stewardship programs that could promote the appropriate antibiotic use, and also to enhance infection control, regular training of staff on recognizing and managing these infections. And the other thing is to establish a system for monitoring infection rates. You have the data. We are always generating this data from the specimens that we test. We can generate the prevalence of these MDROs or VRE in our facilities, and also to collaborate with public health in raising awareness about these VREs. Okay. Then we have the carbapenem-resistant Enterobacteriaceae. This one is a very stubborn bug. These Enterobacteria that are carbapenem resistant are normally classified as extensively drug resistant because they cannot be treated by the simple penicillins, they cannot be treated by cephalosporins, and they cannot be treated with carbapenems. Carbapenems include the drug like meropenem, which is a reserved antibiotic, and they cannot be treated with this. So it presents a challenge that you find that it was a case of carbapenem-resistant Enterobacteriaceae, which had primarily affected patients who had recent healthcare exposure, including surgery and long-term catheterization. So in this case, we juggled our mind along these points, that what strategies could have been employed to raise awareness about CRE. CRE is carbapenem-resistant Enterobacteriaceae, in healthcare providers, and how many community hospitals, and how can community hospitals ensure that they have the necessary resources to manage MDROs, and what role does patient screening play in preventing the spread of CRA? So let's see the challenges that we faced and how we address them. So the facility had limited resources and expertise in managing CRA. Majority of healthcare workers, nurses, and even clinicians are not aware of these organisms, the CRA, the MRSA, and the ESBL producing organisms. Most of them are not aware of these bugs. So we need to do enhanced infection control so that we strengthen the principle of hygiene, contact precautions, and environmental cleaning protocols. Please, when you have those environmental charts in your laboratory, it's not just a document for just filling it out. Ensure compliance. Fill it out that you've really disinfected your surfaces, the high-touch surfaces, your equipment, and everything. Then we also have providing education. Continuous training is always important, and patient screening also when we are implementing the screening protocol for patients at high risk of CRE colonization. High risk, majority of high risk colonization patients are those who are catheterized, having urinary catheter, CVC, and also the draining ports when they have undergone some surgeries. And also when we collaborate with infection control specialists and public health, we can really improve the outcomes and in combating this carbapenem-resistant organism and basically all the other resistant organisms. So the prevalence of MDRO in healthcare. So you notice that globally, antimicrobial resistance has contributed to more than 700,000 deaths in each year. And that number is expected to even reach 10 million by 2050. And the prevalence of this organism is driven most of the time by the misuse and overuse of antibiotics and lack of effective infection control. This is according to WHO, and it was a report done in 2020, which also showed that 50% of bloodstream infections, which were caused by Klebsiella pneumoniae, were resistant to at least one last-line antibiotic, such as carbapenem. A good example is meropenem. Okay. Okay. Next. So in Kenya, like many sub-Saharan African countries, we face a very big challenge in the rising prevalence of MDROs. The healthcare system specifically is very strained with limited access to advanced diagnostics and new antibiotics. It's very rare to find these reserved antibiotics in good supply in public hospitals specifically. And a study in Kenyan hospital also revealed that there were around 60% of bacterial isolates in a tertiary hospital that were resistant to commonly used antibiotics, such as those penicillin, cephalosporins, and quinolones. This is according to the article of Tropical Medicine and Healthcare and Medicine and Health. So additionally, these high rates of carbapenem-resistant Klebsiella have been documented in neonatal ICUs. And you know that these are little babies and they are posing a critical threat to this vulnerable population like the newborns, and specifically individuals with comorbidities. So we look at the community impact and the burden of MDROs. So in a study done in 2022, it highlighted that the colonization of individuals with multi-drug resistant in rural communities, complicating treatment for common infections like UTI and pneumonia. This specifically was attributed to the fact that we are having over-the-counter prescriptions in even the pharmacies outside there. We're having over-the-counter prescriptions for infections like UTI and pneumonia. And sometimes it's not even the UTI or the pneumonia that is ailing them. Maybe the pneumonia that they're projecting it to be might be a viral infection. So this misuse and overuse of these antibiotics is actually contributing to the development of these MDROs. And the prevalence of MDROs is not just a local problem. It's a global public health emergency because antibiotic-resistant infection, they increase the burden on our healthcare system. So the burden, to be specific, is because these MDROs, because they offer very little treatment options, you will find that the mortality and morbidity rates are going high, and this causes a prolonged hospital stay, a higher healthcare cost, and increased risk of complication and death. And also, the treatment options are limited, as we have said. So this spread of MDROs is making the antibiotic or the options for the antibiotics that you are going to use to be more difficult and to shrink the available antibiotics that can be used to treat these infections. And there's also an economic burden because MDROs will strain the healthcare system. The cost of treating the infection can be even 10 times higher than treating non-resistant infections because the drugs are expensive, the patient is staying long in the hospital, and also the ICU charges are not that cheap. So you'll find drugs like the reserved antibiotics. A good example is Zavicefta. A single dose of Zavicefta goes for around 10,000 to 15,000 Kenya shillings. And you find that this might be needed maybe to be administered for 10 days. So you can imagine a 10-day treatment regimen for Zavicefta can cost up to 150,000 Kenya shillings just for that single drug to be administered. And also you'll find that majority of these patients will be treated by the ICU. And the ICU charges ventilation, continuous renal replacement therapy, because the drugs that are also being used, they are also very strong and they can strain the kidneys. So the patient needs to be on CRRT or continuous renal replacement therapy. And also we have the impact on the vulnerable population, especially the immunocompromised individuals and the newborns and the elderly, and patients also undergoing invasive procedure. They contract these MDROs and the neonatal and intensive care unit closely and should be closely monitored for these MDRO outbreaks because we will end up losing the newborns and we end up losing these people with comorbidities. So the impact of antibiotic misuse and overuse. So this plays a critical role in driving resistance by increasing selective pressure on bacteria. So in any case, when you are overprescribed an antibiotic, for example, for a viral infection like the common cold, you know very well that this was not necessary. But this unnecessary exposure, especially to the human microbiota, will increase the selective pressure, and this will yield these multidrug-resistant organisms. And also there's inappropriate dosing. Incorrect dosing, either the dosage is too low or too short a period, can also allow the bacteria to survive and develop the resistance. And in some cases, you find doctors doing empirical treatments that are not necessary. They are going for reserved antibiotic as empirical treatment when we have the access antibiotics and maybe the watch antibiotics that can be used in this case. So this one also exposes the organism to multi-drug resistance. We also have misuse in agriculture. Nowadays, you find that animal farming or animal feeds are also they are included with with antibiotics to treat to give the animal farming, as in the case of herding and rearing of cattle, and also the poultry farming. They are giving antibiotics they're administering antibiotics through feeds in order to minimize the chances of these animals getting sick. So in that case, the animals excrete the same antibiotics in the environment, and the environment will get contaminated by such fecal matter in the environment. And this fecal matter will lead to resistant phenotypes like the Campylobacter and Salmonella species that have been found in livestock and can be transmitted to humans via contaminated food. And also we have self-medication, and that is actually self-prescribing and incomplete courses. So many regions, you find that people just go ahead especially here in the Kenyan setup, you find that most people just walk into a pharmacy, and because one antibiotic worked well for them, they will ask for that antibiotic in case of another infection, or in case of another person gets an infection. So this also fosters resistance, because the drug might be inappropriate and the dosing might also not be appropriate. Also, people fail to complete their doses. So this leaves some strains of bacteria behind that can pass the resistant genes to other bacteria. We shall have an overview of common MDROS, and I'll go through very fast. As we had mentioned earlier, we have MRSA, or methicillin-resistant Staphylococcus aureus. This one is most notable by, you will note it by its resistance to methicillin and other beta-lactam antibiotics, including penicillins and amoxicillin. Normally, in diagnosing MRSA, if you are using this platform such as Bitech, or you are also doing the manual sensitivity, you need to have the oxacillin disc, or you need to have oxacillin in your antibiotic panel that you are testing the organism against. So if you see you've isolated a Staphylococcus aureus and it is resistant to oxacillin, or cefoxitin, in that case, can be also an option. If you don't have oxacillin, you can use cefoxitin. If it is resistant to cefoxitin or oxacillin, know that you are dealing with an MRSA. And its clinical significance, it includes, it's very responsible for skin and soft tissue infections, and pneumonia, and also bloodstream infections and surgical site infections. And MRSA are particularly problematic in hospital, but community-acquired strains are also on the rise, because we say that these organisms are leaking into the community. Then we have vancomycin-resistant enterococci. These specifically, we are talking of Enterococcus faecium and Enterococcus faecalis. When they develop resistance to vancomycin, and when you isolate Enterococcus faecalis or faecium, and you find vancomycin is resistant, know that you are dealing with VRE, or vancomycin-resistant enterococci. So in this case, VRE is responsible for bloodstream infection, UTIs, and wounds. Patients in healthcare setting, especially those with weakened immune system, are at the highest risk. VRE infections are very difficult to treat due to limited alternative antibiotics. Then this one is the common one, extended spectrum beta-lactamases. This ESBL, or ESBL producing organism, they include the gram-negative bacteria, Escherichia coli and Klebsiella pneumonia, and other Enterobacteriaceae that you know of. So they break down a wide range of beta-lactam antibiotics. These are specifically penicillins and cephalosporin. That is amoxicillin. Talk of amoxicillin, talk of ceftriaxone, talk of cefazolin. And also you'll find they're also resistant to beta-lactams antibiotics like amoxicillin clavulanate. So their clinical significance that they are responsible for UTIs, intra-abdominal infection, and sepsis. They cause a variety of infections. And this presents a challenge, because if you find an ESBL phenotype in your cultures, know that you are dealing with a very bad phenotype, or a very multi-drug resistant phenotype, which also has the potential to develop into a carbapenem resistant. So the only option that is there is to use the carbapenems as the new agents for the treatment. But these are reserved for severe cases. Then we have the CRE, or the carbapenem resistant. This normally, when you find your cultures, you've isolated gram-negative organisms such as E. coli and Klebsiella pneumoniae, and you find that meropenem is resistant. You will also find in that case that also all cephalosporins will be resistant in most scenarios, including amoxicillin clavulanate, all the penicillins, and all the cephalosporin. In some few cases, you might find third generation antibiotics of cephalosporins, such as ceftazidime and cefepime, might be sensitive because they are third generation cephalosporin. But in most cases, when you are dealing with this organism and you find that meropenem is resistant, when you're doing your cultures and you're reading plates and your sensitivity, or maybe you use the automated platforms such as Vitek and Mindray, and you find that meropenem is resistant, know that you are dealing with the carbapenem resistant Enterobacteriaceae. And its significance, it causes pneumonia, bloodstream infection, and in this case, they are very severe and they are resistant to most antibiotics. They carry a high mortality rate, and infection can spread rapidly in healthcare setting if you're not careful. Then we have the mighty Acinetobacter baumannii. This one can even sometimes develop pan-resistance. All the antibiotics that you can test in that profile might end up being resistant, including the reserved antibiotic. So Acinetobacter baumannii is a gram-negative bacteria that has become resistant to a wide range of antibiotics, including carbapenems. So when we graduate from ESBL, we go to carbapenem resistant, then we go to PDR, or pan resistant. And one of them is also Pseudomonas aeruginosa. This is a gram-negative bacterium, and it's very, very, very notorious. This one can also develop resistance against also beta-lactams and fluoroquinolones and aminoglycosides. We'll see its main mode of acquiring this resistance, or its resistance mechanism, as we'll see later. It's very interesting. So the clinical significance, it causes serious infections in immunocompromised patients, particularly healthcare settings, such as ventilator-associated pneumonia, UTIs, and surgical infections. So its resistant to many antibiotics makes treatment challenging. Then in addition to this is actually not traditionally being classified as MDRO, but it comes as an aftermath of overuse of antibiotics. So long-term use of antibiotics causes this Clostridium difficile infection, or clostridiosis. So it causes severe diarrhea and colitis because somebody has been in treatment for so long and the good bacteria or the good microbiota in the gut has been depleted. So actually, when a patient acquires clostridiosis or Clostridium difficile, it can also spread to those who are immunocompromised, which can also be a cause for alarm and a call for infection control. Thank you. So we look at mechanism of resistance. In mechanisms of resistance, the antibiotics, this resistance rises when bacteria evolve the mechanism to survive exposure to antibiotics. So, and the funny thing is that this resistance happens so fast that you won't even notice it. So the genetic changes, mutation, and acquisition of resistant genes combined with selective pressure, particularly from the misuse and overuse of antibiotics, this is what causes this resistance. The misuse, overuse of antibiotics, and genetic mutation. So we have mutations. In this case, the bacteria was during the replication of the bacteria, this random mutation can occur. In these cases, this affects the targets for the antibiotics and allow the bacteria to survive the exposure to the drug. Once this mutation occurs, the selective pressure from the antibiotic use will allow the resistant bacteria to multiply and even dominate. So the good example is TB, undergoes spontaneous mutation in that gene, the RPOB, the RNA polymerase gene, and this will prevent the rifampicin from binding to its target. So as a result, the bacteria just becomes resistant to the drug. So this leads to what we call the MDRO, the multidrug-resistant tuberculosis, which often requires stronger and longer therapies and even more toxic treatments. Okay. Then we have horizontal gene transfer. This includes conjugation, whereby the bacteria transfer the genetic material through cell-to-cell contact via plasmids. This one is through plasmids. Like, for example, the plasmid-mediated resistance Enterobacteriaceae, the E. coli and Klebsiella pneumoniae. They can share the resistant genes through plasmids. So this one will lead to carrying maybe one bacteria carries the gene for extended spectrum ESBL, extended spectrum beta-lactamases, and it passes to the next bacteria. And like that, the other bacteria also develop penicillin and cephalosporin resistance. So the ESBL gene, they really pass very rapidly, more than we even invent new antibiotics. So new antibiotics can take up to 10 to 15 years, but this one can take just days to pass these resistance genes. So this ESBL producing organism can cause very serious infections that are resistant to many used antibiotics, like now the carbapenems. Okay. Then you have transformation, whereby this bacteria will just take up the DNA from floating in the environment and they include it in the resistant gene from the dead or lysed bacteria. So a good example is Streptococcus pneumonia, which acquired genes that alter penicillin binding proteins, PBPs, from other dead bacteria. So the dead bacteria which are there, maybe you used an antibiotic and it killed that bacteria, but in the process, the bacteria had already acquired the resistance against penicillin. So that bacteria will gain that gene from the dead bacteria and it will pass to others. So this mechanism will make even infections like pneumonia harder to treat, especially acquired pneumonia. Okay. We have also transduction. Is whereby bacteriophages, these are bacteria that infect these are viruses that infect bacteria. So you'll find while this virus like adenovirus will infect a staph aureus that had methicillin resistance, and when it infects the staph aureus, the bacteriophages or that virus will carry the same gene to the next bacteria, which had maybe like they make a gene that is in the Staphylococcus aureus, which is responsible for methicillin resistance. It will carry it and pass it to the next bacteria, and in that process, that bacteria will also gain resistance by altering its PBP gene, which will make it difficult to treat this infection. This MRSA will normally cause severe hospital and community-acquired infections, including skin infections, pneumonia, bloodstream infection, which makes it one of the most notorious resistant pathogens in the world. So selective pressure, as we had said, this one is exposure to antibiotics. When the bacteria gets exposed to these antibiotics, we have beta-lactamase production. The bacteria will produce beta-lactamase enzyme that will hydrolyze the beta-lactam ring found in antibiotics like the penicillin, cephalosporins, and carbapenems. This leads to inactivation of the drug. So we have this ESBL producing organisms like E. coli and Klebsiella, which are resistant to penicillin and cephalosporin, and even sometimes these monobactams like avibactam and also aztreonam. These enzymes can degrade the beta-lactam antibiotics even before they reach their targets in the cell wall. So this is just an enzyme that is produced because the bacteria has been exposed to these penicillins and cephalosporin for so long, and now it develops the resistance. And this will cause complicated UTIs, bloodstream infection, and will limit options to carbapenems or new antibiotics. Then we have aminoglycoside modifying agents. So these are bacteria that chemically modify aminoglycoside. Like aminoglycoside, a good example is gentamicin and tobramycin. It does this through acetylations, phosphorylation, and adenylations. This prevents antibiotics from binding to its ribosomal target. This is a good case in multidrug-resistant Pseudomonas aeruginosa. The bacterium can modify aminoglycoside, which renders them ineffective. So you'll find even in the revised version of M100 CLSI guidelines, you'll find that aminoglycoside, most of them are not recommended to treat Pseudomonas aeruginosa. So infections with multidrug Pseudomonas are difficult to treat and often require combination therapy with antibiotics that are more toxic or less effective. So like we said earlier, there's also alteration of the PBP or penicillin binding protein. These PBPs are the target for beta-lactam antibiotics. So the drug can no longer bind and inhibit the cell synthesis. Example is MRSA, which carries the make a gene that encodes PBP protein. So MRSA are very resistant to most beta-lactam antibiotics during treatment with other classes, such as vancomycin or newer drugs like linezolid and daptomycin. So it leads us to use even more stronger drugs, and which also make us to make also this organism to develop resistance against this linezolid and daptomycin or these strong antibiotics. And we also have ribosomal protection, which is altering the structure of the ribosomes. The target antibiotics like tetracycline, macrolides can no longer bind effectively. So tetracycline-resistant Streptococcus pyogenes, we've seen it, the TET-M gene encodes proteins that protect the bacteria from ribosome tetracycline binding. The impact is that this resistance limits the use of tetracycline, once widely used for treating respiratory infection. So we no longer use tetracycline in treating respiratory infection because it has been rendered useless, leading to reliance on other antibiotics with potentially more side effects. Then this is the most interesting, method of antibiotic resistance, typically for Pseudomonas aeruginosa. So the Pseudomonas aeruginosa has tripartite or efflux pumps, MXA, those were listed there. So imagine that this Pseudomonas aeruginosa that is pan-resistant has the ability, when antibiotics permeate through its cell membrane, it has these pumps that just pumps out the antibiotic. So this leads to the pan-drug-resistant nature of the Pseudomonas aeruginosa. So once you isolate a Pseudomonas aeruginosa that is resistant to almost all the antibiotics, know that it has this mechanism, the efflux pumps, that are pumping out all the antibiotics out of the cell wall, so out of its cell structure. And also we have the reduced permeability. This bacteria will reduce the number of porins on their cell wall. So by closing the cell, the number of channels that the antibiotic can enter into that cell or into the bacterial cell, this causes the resistance. Example is carbapenem-resistant Enterobacteriaceae that reduces the expression of porins in the outer membrane, which prevent carbapenems from entering the cell. At the same time, they may produce carbapenemase. That's also an enzyme that can degrade the carbapenems. A good example of carbapenem is meropenem. So the impact is that the CRA infection will be highly resistant to all available antibiotics, which will lead to increased mortality and limited treatment options. So how do we prevent? Because that's the major thing. And it's very simple because we see that developing new antibiotics will take time. So the only way we can face this challenge is through prevention. And one of the way we can do that is through environmental cleaning and disinfection. These MDROs can survive on surfaces for extended periods. So we need to do frequent cleaning with the specified or the certified antiseptic or disinfectants. So through cleaning of our environment and high touch surfaces like the bed rails, the doorknobs, and medical equipment, even in our labs, disinfection, especially the microbiology area. If you are not doing thorough environmental cleaning and disinfection in your microbiology department, believe me, you will be getting sick frequently. And that is because of this organism. So there should be thorough cleaning, especially in those the high dirty areas, the areas that you are doing your cultures, the area that you are handling your specimen, in the sample collection rooms. Ensure you do proper and thorough cleaning. This is the only way we can prevent these MDROs. Then we have education and training. So normally, we usually have high staff turnover. And because of that, education and training should be continuous. As we absorb new employees or new healthcare workers into our systems, ensure they are regularly trained and updated on infection prevention protocols, and also educate patients and visitors on the importance of hand hygiene and contact precautions. Always do that. Then screening and surveillance. We should be conducting this quite regularly. Then we have also contact precaution, as we had said earlier on. We need contact precaution to prevent patients from transmitting the MDROS to other patients. So contact precaution is you wear your protective equipment and how you wear your personal protective equipment, gloves, gowns when entering the patient rooms and handling contaminated materials. That one we know. We properly disinfect equipment and surfaces in patient rooms to prevent environmental contamination. Then antimicrobial stewardship is very important, though majority of this one can only be achieved by establishing an antimicrobial stewardship committee. This one, I know it's a hard task because getting to coordinate doctors, nurses into understanding the impact of MDROS is very hard, and you will meet a lot of resistance because doctors will be over-prescribing stronger drugs, when in your microbiology report, you've even offered less expensive and less toxic drugs, but they'll be opting for the one that is even stronger because they believe it will kill it easily. So we need to use antibiotics when necessary, according to evidence-based. We review antibiotic treatments regularly. We de-escalate where it's appropriate. We switch to those narrower spectrum agents, or we even discontinue antibiotics when there is no sign of infection or no evidence that this person has been colonized by a bacteria. Also, we need to promote the diagnostic tools to distinguish between bacteria and viral infections so that we reduce unnecessary antibiotic prescription, especially for viral infections. Okay, so the gold standard for diagnosing MDROs is culture-based. So this one is also time-consuming, as we know, but it's the gold standard. But it's time-consuming. It takes somewhere between 24 to 72 hours, depending on the specimen and also depending on the results that you'll get. If you get an MDRO by testing the general antibiotics that are commonly used, you'll need to repeat another testing to do sensitivity with strong antibiotics. So that can take even more than that, 72 hours. So you can pair this with disk diffusion, and automated systems are there, like Vitek 2 and Mindray, which determine the antibiotics that are effective or those that are from those that are not effective. Okay, we have also molecular methods such as PCR for MRSA, multiplex PCR, whole genome sequencing. This one will provide quicker results, but they are very expensive. Like you find most of these PCR panels, they are these syndromic panels. Like we have a good example is blood biofire. We have another one that is maybe a respiratory panel, gastrointestinal panel. This one will detect the organism very fast, but the problem comes that it's very expensive. A single test can cost around 20 to 30,000, of which most people cannot afford. Then there are also some rapid phenotypic methods whereby they can help in bridging the gap between molecular diagnostic and traditional cultures and provide a relatively speedy and cost-effective options for determining what organism the patient is suffering from. So this rapid phenotypic assay can determine or identify the pathogen and its resistant profile in a shorter time frame compared to conventional cultures. So we have MALDI-TOF. This can rapidly identify bacteria and fungi by analyzing protein structures and combined with antibiotic-resistant database. So MALDI-TOF is there. It can also predict an MDRO profile. The result is typically under 24 hours, but significantly, it's faster than traditional methods. So we also have rapid antibiotic susceptibility testing. We have automated systems that detect resistant phenotypes within hours by measuring the bacterial growth in the presence of antibiotics. and it's becoming increasingly available. You can find this online. Then these methods shorten the time to effective therapy by quickly determining resistant patterns. These are some of the new technologies that are coming up. Then we have the next generation diagnostics. These are emerging diagnostics tools which are aiming to combine speed, accuracy, and comprehensive resistance detection, especially CRISPR-based diagnostic, which uses the CRISPR technology to detect resistant genes and offers potential for ultra-rapid and high-specific MDRO diagnostic. So it goes specifically, it diagnoses a bacteria, it analyzes its genome and detects the resistant patterns. And also we have nanotechnology-based platforms, which is also being explored for rapid detection of MDROs using nanoparticle-based biosensors to detect bacteria or resistant genes in real time with high sensitivity. We're also having point-of-care testing tools such as handheld devices for using microfluidics and isothermal amplification techniques. This one, we've not yet embraced it in Kenya. It's still a work in progress, which actually the patient just touches the device and it detects the kind of infection the patient is having, and also it can be used in the outpatient settings, which minimizes time between sample collection and diagnosis. It will be interesting to see. So what are some of the interventions or the ongoing interventions that we are having? So first, these are research that are ongoing. And they say with every challenge comes opportunity. So as medical laboratory officers, as the generators of this data, as the handlers of this specimen, as the custodians of these cultures, we have all the tools and we have everything that we can do to engage in these ongoing interventions. Just write a proposal and try to do your research on this and maybe find partnerships with other IVD companies. They can help you in research and you can come out with a very groundbreaking innovation, which will help to solve many problems. So we have genomic surveillance, establishing global networks for real-time monitoring of MDROS outbreak so that we understand trends and transmission patterns, which will aid in public health responses. So we need to coordinate all our hospitals together so that we know the prevalence of MDROs so that we can have a larger database to help in groundbreaking innovations. And also there are also ongoing environmental studies, which is investigating the role of environmental factors such as agriculture and wastewater in the rapid spread of MDROs and how they contribute to human infections. Sewage, you can take sewage water and test it for these MDROs. Take sewage water and do your cultures. Find out and approach the public health department and tell them, hey, you see this is what I've found out. We see so many sewage water leaking in our streets and in our environment. That's an opportunity to do a research and see how that sewage water is contributing to to the spread of MDROs in our communities. Also, there's vaccine development, which are ongoing for specific MDROs, which is aimed to reduce the incidence of infections caused by these pathogens. Collaborative initiatives that are also increasing between the academia, the industry, and governments to foster innovation and streamline the development of new antibiotics and treatment modalities. And also we have the microbiome analysis. There are research ongoing on how the human microbiome plays a role in resistance and susceptibility to infection. Because when you are consuming these antibiotics, they are going into your gut and they're being excreted through feces. And we have Enterobacteriaceae in the gut. So in the process of us taking these antibiotics, are we also creating a menace to the environment? That's the question that's some of the analysis and researches that is going on. So we need to have accurate and rapid diagnostic testing so that we guide timely and appropriate therapy. So we know that results delayed is results denied. So when you are coming with these guidelines and we are coming with these new innovations, we need to consider time. When we reduce the turnaround time for results, we are increasing the the detection rate, and we are also increasing the chances of starting a targeted therapy so that reduce the risk of promoting further resistance. So we are also targeting the reduction of mortality when we are doing the rapid diagnostic. We are doing when we are doing accurate and rapid diagnostics. We are also reducing the mortality rate so that the vulnerable population in the ICU patient, they can recover and also come back to their life. It's so sad to see those patients in ICU suffering and being colonized with this multi-drug resistant organism. And you know very well that it will be very hard for them to come back after being colonized with such organisms. And also we have antimicrobial stewardship. Please, let's embrace this. Antimicrobial stewardship is very important. We as the lab people, we need to come up with data and show clinicians that this is how these antibiotics are performing against these drugs. A recent research was shown that now meropenem, which is a reserved antibiotic, has efficacy of less than 70%. So you can imagine what of these other cephalosporins. And it was also shown that commonly used antibiotics such as ceftriaxone was having an efficacy of less than 40%, meaning that if you take this microorganism, when somebody is infected with this microorganism, the chances of ceftriaxone working has now reduced to 40%, and meropenem working has reduced to 70%, which was earlier at around 90%. So we need also to ensure infection control is also timely. Early identification of MDROS in the environment will quicken faster implementation of infection control practices, which reduces the risk of transmission within the healthcare facilities. Okay. So what are the challenges associated with MDROS? As we had said, we have limited options for the antibiotics because MDROS will have you just a narrow spectrum of antibiotics that you can use, and most of them are reserved antibiotics. And also there's increased severity of infection because when an infection is not treated, especially to immunocompromised people, the treatment options are limited, and this causes the infection to spread even further. We have also adverse effect and toxicity. The alternative antibiotics that are being used, such as polymyxin, that is colistin, will cause nephrotoxicity. Aminoglycoside also causes ototoxicity. It has been shown that when you use a lot of aminoglycoside like gentamicin and amikacin, ototoxicity, you hear that ringing sound in the ear, the bell sound in the ear, the ringing sound in the ear, the ringing ears. Nephrotoxicity, especially when you are using colistin, will end up causing acute kidney injury. So that shows you how important it is. We should curb the spread of MDROs so that we reduce the complications caused by these MDROs. And also pharmacokinetics and pharmacodynamics challenges. So to achieve the concentration of antibiotic in the site of infection can be challenging, especially in biofilm-associated infection. Another method of, or maybe patients with altered pharmacokinetics due to comorbidities. So the treatment options that are there is the use of ceftazidime avibactam, combination of this third generation cephalosporin. These are new antibiotics that are coming up. Ceftazidime avibactam is commonly known as Zavisefta. If you've seen a patient prescribed Zavisefta, and you see some doctors prescribing Zavisefta and the patient doesn't have the MDRO. So you can imagine they are contributing to the selective pressure being put on this organism to develop even resistance. We have meropenem verbobactam. This is also a combination therapy. Imipenem cilastatin relebactam is a combination therapy. Polymyxin B, that is colistin, and polymyxin B. So these are older antibiotics. They're being retired, but they are going to work. So there are ongoing researches on alternative therapy that includes monoclonal antibodies, investigating whether we can use antibodies to target specific pathogens or their toxins. There's also research ongoing on bacteriophage therapy, that is using the viruses that normally kill these bacteria. So you are coming up with a virus that will be benevolent to your body and only target the bacteria. It's an interesting one, what we'll see about it. Also, antimicrobial peptides. These are naturally occurring peptides that can exhibit antibacterial properties. So these can serve, they show promise against resistant organisms. And combination therapy, most of it is happening already, using 2 or more antibiotics simultaneously, like maybe you use colistin plus tigecycline, it can work, which these antibiotics have synergistic effect, and adjunct therapies. So certain cases of adjunct therapy will be immunotherapy, so that you're using immunomodulators or vaccine that may enhance the host response to infection and help control MDROs. We need multidisciplinary collaboration in addressing the challenge of MDROs. We cannot win it alone. So we need to establish clear communication channels. So in these multidisciplinary collaborations, it can be fostered through developing an antimicrobial stewardship committee, which will clearly outline the role of each team member. That is either the doctor, the nurses, the infection control specialists, and pharmacists in managing MDROs. In most clinical settings, you will find that the lab has not included MDROs among their critical or panic values or critical values. These MDROs need to be included in your panic values or critical values, because if you find out that you've tested a sample and it is a multi-drug resistant organism, you need to make a call to that doctor. You need to make a call to that nurse and inform them that I have isolated a multi-drug resistant Pseudomonas aeruginosa. The drug that you are using there, maybe it is ceftazidime, it's not going to work. It's a critical value that will cause a change in the therapy for, in the administration of the drug, the choice of drug for the patient. So this collaboration, we should collaboratively develop and implement guidelines for the prevention and management of MDROs that incorporate input from all disciplines, so that we ensure protocols are evidence-based and regularly updated to reflect the latest research and best practices. The lab plays a very key role in developing of the antibiogram. You come up with those antibiograms and you tell the facility that these are the drugs that are working and these one are the ones that are not working. So we also have joint training and education. We implement joint training session in MDRO prevention. Continue doing that. Encourage participation in interdisciplinary workshops and seminars to enhance knowledge and skill. Then we also need to leverage on technology. We use these electronic health records to facilitate real-time data sharing and enhance coordinated care efforts. For example, the pharmacy can block doctors from using reserved antibiotics when a patient, it has been shown in the lab report that other access and safer antibiotics can be used instead of the reserved antibiotic that the doctor wants to prescribe. So we also need to implement alert system for MDRO detection that involves all relevant teams. As I've said, we need to include this MDRO in our panic values. Okay. So also another thing, we need to engage patients and families. So involve patients and tell them, let them help you, because these patients, they are coming to see, these maybe family members, they are coming to see their patient in the wards, and they are not aware of infection control and prevention measures. So they will greet the patient, hug the patient, get that infection from the act as a vector of the bacteria from the patient and take it out to the community. So this one will increase the chances of the community also getting infected with these MDROs. So we also need to educate them about hand hygiene, about contact precautions. Tell them the truth. Your patient is suffering from this bug. You don't need to be that close to them. You need to do this and that. Thank you so much. And it was nice having this discussion. My parting shot to you, or my closing remarks, is that the rise of this superbug is one of the greatest tests of modern healthcare, but it's also our greatest opportunity. So we need to strengthen our systems, we need to educate, we need to innovate. We as the medical laboratory professionals, we don't just process samples, we safeguard lives. So let's make the resistant the exception, not the norm. Thank you so much.
Thank you so much, Samuel, for that wonderful presentation.
Okay.
Yeah, it was an eye-opener. Thank you so much, even from the people people, the participants' charts here. If I can read a few, is
Okay.
that Ambrose Cardinal is saying very informative session. Boston
Thank you.
Moranga saying wonderful presentation. Mercy Lutoka, good presentation. Okay.
Thank you so much.
Shem Nyasende has a comment. MDRO are common UTIs.
Okay.
I don't get it. MDRO are common UTIs, are resistant to most drugs. People are abusing antibiotics, even ceftriaxone can't cure most UTIs.
It's no longer working.
Okay.
Yeah.
Yeah. Asha Hamisi, excellent presentation. Okay. Yes, from the charts, I can see people are appreciating the presentation. Thank you so much. Maybe we can go to the Q&A. I can see a few questions.
Yes, okay.
Let me start with the Lilian Ouma. Lilian Ouma is asking, you've talked about rural community as one of the challenges complicating treatment of UTI on MDRO. Please elaborate on this and what is the government doing about it? Otherwise, it was a wonderful presentation.
Okay,
So
can I just take them as okay? So to elaborate on that, in the rural setup, majority of this rural setup, you'll find that these patients are taking most of this over-the-counter medication. For example, somebody might just be having a simple viral infection, a flu, for example, that is viral. But they will go to a pharmacy, and the pharmacy guy or the farm tech will prescribe, for example, amoxicillin clavulanate. In this case, amoxicillin clavulanate is used to target, it's an access antibiotic, I understand, but it's used to target bacteria. And in this case, this person doesn't have any bacteria or bacterial infection. So as I said earlier, this person, when he takes this antibiotic, he has the microbiome. And this microbiome, you are exposing your microbiome to antibiotics. The microbiome are these Enterobacteriaceae that you are talking about, the E. coli and all that, the Klebsiella, they are normal floras in the stomach. So when they are taking these antibiotics, you find that they are exposing these Enterobacteriaceae to antibiotics, and these Enterobacteriaceae will develop what we call selective pressure towards these antibiotics. They will get used to these antibiotics, acquire genes to resist amoxicillin clavulanate, and that's why you find a breakout in ESBL, because you also find in rural settings, hygiene is poor, and when hygiene is poor, this fecal matter will leak into the environment, and people will get this infection, these fecal-oral infections, which also include bacteria. And now, in that case, you will find that these multidrug-resistant organisms will start spreading in the rural areas. That is the main issue. And what the government can do is to make policies, that will restrict pharmacies from over-the-counter prescription of antibiotics, that you can only be prescribed antibiotics upon evidence-based results, that you've done a culture, or you've done a hemogram, or you've done a PCT, and there is evidence that you are suffering from a bacterial infection. So correlating with the clinical symptoms of the patient, you can conclusively say that this person really has a bacterial infection. But in the case of somebody just having a flu and going to seek the over-the-counter medication, this will lead to this explosion of MDROs. I think that answers well.
Thank you so much. Please. Yeah, I also want to advise our members, you can also ask your questions by raising your hand. I can give you the mic and ask it orally. Another question is from Wilfred Moriasi. Wilfred Moriasi is asking, I have seen we have emphasized on overuse, overdose. What about the effects of underdose or misdiagnosis or misprescription of antibiotics?
Yeah, I think I touched on that. I said it's either too low a dose or too high a dose. And also when you are talking about misprescription, we are talking about empirical treatments. When I talked about empirical treatments, you find that in some scenarios, it was just appropriate to prescribe amoxicillin clavulanate in the treatment of a respiratory tract infection like pneumonia. But the doctor goes overboard and prescribes a strong antibiotic like meropenem. Yet, amoxicillin clavulanate could have worked. So in terms of its prescription, talk about misuse of not doing this, not doing the correct, not following the correct empirical treatment that are suggested there by the Ministry of Health. And also in prophylaxis. For example, patients who are going for surgeries, you find doctors, maybe for a certain surgery, it's recommended the doctor should just use ceftriaxone and metronidazole combination, for example, in CS. But you find a doctor going for meropenem in empirical treatment. So that one is also creating selective pressure that yields MDROS. Thank you.
Thank you so much. Another question is from Fatuma Yusufu. And
yes.
She's asking, how do we prevent MDRO to long-term medication users?
Okay. Long-term medication users, you can talk of maybe those who are on TB treatment. But long-term medication should also be clinically substantiated. For example, for those who are on TB treatment, those one we can say they should be on long-term medication, maybe about 6 months of taking rifampicin or isoniazid. But there is no ground to prolong treatment without any clinical justification. For example, you can change antibiotics, maybe after doing one antibiotic and you find that it's not, and maybe after, there's normally escalation and de-escalation. When you find that maybe a patient has come to the emergency, and when he comes to the emergency and you are also requested to take maybe urine cultures and blood cultures, and the patient is started maybe on ceftriaxone, and now upon culture results coming out, you find that these results are showing that the patient is, the bug that you've isolated is resistant to ceftriaxone. So the doctor might shift to maybe a higher antibiotic, a reserve antibiotic, or maybe because of ceftriaxone is in the access category of antibiotics, this doctor can shift to the watch category of antibiotics, and maybe you've prescribed that the best antibiotic that can cure this patient with less toxicity is ciprofloxacin. So the doctor can shift to ciprofloxacin. But I don't think if there's any clinical, if there's any justification for long-term medication without a clinical basis. There must be a clinical basis. And in most cases, it's maybe TB treatment, which normally takes a longer duration of time. Or maybe it's also an MDRO, and in MDRO, the patient will just be treated with the available antibiotics that are there, or maybe it's a pan-resistant organism. And this pan-resistant organism, the doctor is just trying to manage the patient as he allows the patient immune system to fight. And when the immune system taps out, unfortunately, the patient will lose the patient. That's unfortunate. Thank you.
Thank you so much. Another question from George Mwaniki. And George is asking, is it advisable to report drug susceptibility test in terms of length of the MIC, or do we just report as susceptible, intermediate, and resistant alone?
Okay. Actually, that begs the question of what's your policy in your microbiology setup. For example, you'll find some laboratories reporting MICs, but interestingly, doctors are misusing MICs. Doctors are taking that a drug with the lowest MIC is the best. And in this case, most of the time, the drug with the lowest MIC will be like meropenem with an MIC of less than 0.25, compared to maybe amoxicillin clavulanate, which is still working, but with an MIC of less than 2 or maybe less than 4. So it's a challenge, But if in your facility you've implemented proper antimicrobial stewardship, it will help guide treatment in any case. That's why I said it's very important. As you go back to your workplaces, think about this. If you don't have an antimicrobial stewardship committee, then you have no power to say whatever you want, because doctors will be prescribing the way they want because you don't have systems. But I would recommend that go with the policy of the hospital. Don't try and change the policy and you've not involved your management. So when you are reporting the MIC, if you are the policy maker, then decide today, I'm not going to report MICs. I'm just reporting sensitive and resistant. Other facilities are also just are doing cascade reporting. In cascade reporting is you just report if the patient has drugs in the access category, or normally normally the lab will follow the CLSI M100. In CLSI M100, the 2025 version, you find that you are supposed to prioritize tier 1 antibiotics first. Report tier 1 antibiotic first before you go to tier 2. That is the good practice. So you can follow the CLSI guidelines. Report tier 1, and if you want to do MICs, that's upon your policy of your hospital. But you can report tier 1 before going to tier 2. That's called cascade reporting. But with regards to answering your question, whether to report with MICs or without MICs, it depends on your policy. And if the problem is that if you umezoesha, as in your doctors are used to you reporting MICs and then you stop, you will face a backlash. That's the problem.
Thank you so much, Samuel. I can see several questions, but because of time, we may not really exhaust all of them. We can take 3 more. I've seen someone is asking for your contact. Yes, we'll send it to you, Rebecca. Ambrose Canal is asking, IPC measures are important in preventing spread. Okay. Would there be any resistance of MDROS on available disinfectants?
Okay. When you are introducing this disinfectant, actually, what you're supposed to do, there are recommended disinfectants in our facilities that the EPA, we call them the EPA certified disinfectants that you're supposed to use. And yes, I can tell you for free that there are disinfectants that are not, that cannot be effective against certain organisms. Normally, you can use 80cc organisms to test for those disinfectants, because we also have a procedure for testing efficacy of a disinfectant before introducing it into use. You test the disinfectant upon the manufacturer's claim. We call it, we verify the claims of the manufacturer. He has stated that this disinfectant is effective against staph aureus, against this and that, at this concentration. So verify. Take the 80cc organisms or whatever organisms that you have reserved there in your lab and test them against those disinfectants before placing them into use. You might be placing a disinfectant into use because they have just claimed that it is effective, and yet you find it's not effective. So it's always very important that before you accept any disinfectant in your laboratory for use, you need to test again. You need to test its effectiveness first. Because sometimes, we know, for example, absolute alcohol will be very effective. We know we have HAZTABs, those chlorine tablets, they are very effective. They cannot be resisted by any microorganism. But we have others, and we have a caveat, especially in those ammonia-based disinfectants. You must test them. The Lysol and ammonia-based disinfectants, you have to test them for efficacy before placing them into use. But as for chlorine disinfectants and alcohol-based disinfectants, those ones have been proven to be very effective.
Thank you so much, Samuel. An anonymous attendee. Case in point, a young baby presenting with fever and restlessness, liquid saliva, congested chest. Which is the best remedy in terms of antibacterials?
Now we have to, as we have said, we are medical and laboratory professionals. We are based on evidence. It's the work of the clinical officer to assess the clinical manifestation of the patient and then request for lab tests. If there is an evidence of bacterial infection, and also the clinical manifestation, maybe it's pneumonia or an infection with a respiratory tract infection, it's recommended first line. Normally we use augmentin, and maybe if augmentin is not working, can shift to clarithromycin and such antibiotics. But I would advise in this case, because you are medical laboratory officers and we don't want to give empirical, we are not so much engaged in empirical treatments. We would advise that you send us the sample, if it is a sputum sample, if it is maybe a throat swab, we do the cultures, we tell you what antibiotic is effective in this case. Can be a lower respiratory tract infection, an upper respiratory tract infection, and there are treatment regimens that are there, the empirical treatments are there, but we need to have the evidence so that we know exactly, as the patient is on empirical treatment, what antibiotics are we, from our side, the antibiotics that we've selected to test on this sample and this organism that we've isolated, what antibiotics are actually effective against. So I wouldn't authoritatively say that this is the antibiotic of use, but I would say normally we start with the empirical treatment as we wait for lab results, because most of our results are culture-based, which take around 24 to 72 hours. So as you are waiting for the lab results, the patient will be on the empirical treatment. And if it's for those respiratory tract infections and maybe such kind of infection, it's recommended augmentin. And if it's not working, maybe, and it's not palatable to the patient, there are many factors to consider. Also, you have to consider if the patient has any reactions, allergic reaction to the drug. So there are many factors to consider in that case. But I would advise, do the cultures. The doctor should request for cultures as the patient is put on empirical treatment.
Thank you so much. I saw a hand. Is Boaz, are you ready to speak? Boaz, are you able to speak? Okay, let me mute Boaz. Thank you so much. The last two questions, if you can answer them together. One is, please elaborate on MIC in culture and sensitivity results. MIC of 4 and MIC of less than 16. Which drug is more sensitive?
Okay.
Yeah, you can go with that first.
Okay, now let me put it in black and white. We don't compare MICs. Why am I saying this? Because MIC is the minimum inhibitory concentration of a drug required to kill an organism. And the MIC, the minimal inhibitory concentration, for example, for a drug that has an MIC of 4, and the minimal inhibitory concentration for a drug that has an MIC of 16, that means these two antibiotics are still effective, but now they will kill the organism at different concentration. MICs are important when you come to dosing. So you will find amoxicillin clavulanate, you have to take maybe 1 gram. And ciprofloxacin, you only have to take 500 grams. So the MICs are the ones that determine the dosing and the what do we call it? The duration of the dosing. That's where MIC comes in. So please, in your lab reports, don't compare MICs. And if you compare MIC, okay, I know very well that ciprofloxacin is in the watch category and amoxicillin clavulanate is in the access category. And you are advised by WHO, go for the access first in order to reduce antimicrobial resistance. If you are going for ciprofloxacin and the bug develops resistance against ciprofloxacin, I'm telling you for free, you've created a bug that will be resistant in future to amoxicillin, and you've contributed to the spread and development of this MDROS. So please, each drug is effective as long as it is sensitive. What matters is the period, the dosage in terms of grams and the duration of treatment. That's where the MIC comes in. Thank you.
Thank you so much. The last question, Jane Mora is asking, please explain how and which bacteria cause ear ringing.
Okay, it's not a bacteria. I said earlier that aminoglycosides, especially gentamicin and micacin, when you are put on those drugs after a duration of time, when you finish the dosing, you start feeling the ringing effect in your ear, like the, what do we call it? Like that sound that comes from the cinema when it's starting, the sound. So you start hearing the ringing. It's a side effect of a drug, but it's not ideally that it's a bacteria that is causing that. But if there is that symptom of the ringing ear, and maybe there is swelling, and there is also fever, that means it might be an ear infection. And you need to take an ear swab, get your cultures, and maybe be put on an empirical treatment as you wait for your results. That's the best thing you can do.
Thank you so much, Samuel Assembly. Yes, we've come to the end of today's session. And
thank you so much.
I want to take this opportunity to thank you on behalf of LMSK for that well-researched topic and also well-articulated. I can only end that with a comment from Levi Maelo. Levi Maelo has said, a good one again. Thanks to LMSK, yes, we are getting somewhere. So it's appreciating so that as lab professionals, we are getting somewhere. Yeah, we are getting somewhere. So just to make one announcement from LMSK is that we are planning to have a dinner on 28th of November, and it will be at Westlands, Pride-In Westlands Hotel. All LMSK members are welcome, and it will be a free event for LMSK registered members. For non-registered members and who would like to register, this is an opportunity to do so. We just visit our website, which is www.lmsk.co.ke, and you buy the subscription that suits you. Otherwise, from our end, we thank you so much, Samuel, unless you have something, your last parting shot for us.
My last parting shot is that as lab technologists, as lab professionals, please let us participate in this advancement in reducing the chances of MDROS. We are we play a very crucial part for such in engaging in these discussions. Include, please, as you go from here onwards, please, any MDRO, report it as a panic value. Contact the doctor, let them know that you are interested, and let them know that, okay, you are showing interest in the patient care, because the more we keep talking about it, the more it will make sense to them. And also, let's participate in these platforms. If there are these committees, please join these committees, the antimicrobial stewardship committees, the infection control committees, and let us be heard. The only way we can make an impact is through our voice. Let us be heard. Let's bring our contributions to the table. Let's discuss, because you find that the lab, it's the brain of the healthcare system. And if the brain fails, the whole healthcare system is in a syncope. So let's educate, let's innovate, let's engage with these clinicians, let's engage with the nurses, let them know that these organisms are there because we are the one that we are experiencing them. And sometimes we find culture reports and you're just so saddened that this patient mostly is not going to survive because there's no antibiotic that's going to work here. And maybe it's a bloodstream infection. So let's engage, let's coordinate efforts together with other departments, and together we shall win this fight against MDROs. Thank you so much.
Thank you so much, all the attendees. We thank you for your time, and we thank you for your contributions towards this session. Hope to see you soon on Monday, when we'll be having another session from 3 p.m. Otherwise, enjoy your great weekend.
Thank you so much. Bye.
See you.